the few revision cases. So this was a 62-year-old lady, rheumatoid arthritis. She had 1 year post-op bilateral total knee replacement. She came to us actually 3 months after this injury on the left side. It's almost like a non-union. So this was the situation. I've got the long leg also. I've got the lateral x-ray. So it's almost like an ununited fracture. And that was a CT also. CT was done just to see what avenues we had for fixation as well. So 2 problems here. She's got a stem down the tibial side. She's got the femur with the non-union, and infection is ruled out. So this was a little difficult to plan because we had to get the stem out from the tibial side as well. So what we did is we did a little bit of trauma management just to, little like a trauma. So we put in a stem on the femoral side, put in a constraint put a constraint construct, and also added a plate on the femoral side. So this is like combining the best of both. So this is basically, as far as distal femoral fractures are concerned, we use a nail plate construct. So this is following the same principles. Yeah, apart from using something like a sleeve or a cone, and that is what, this is at 1 year as a follow-up. It's got good bone formation, the fracture is united, and that is her range of movement as well. So if you look at it, we did that. So anything different that would have been done, that's why I ran through the case for lack of time. Any yes from the floor? Good question, but I got through 3 screws, unicortical screws proximally. This is classically the same as a nail plate construct. Longer plate wouldn't have probably helped much. Both of them end at the same level, okay. But I was not too concerned about that because the bone stock above was quite good. Yeah, that's a valid point. I could have probably extended the plate a little bit more. Okay, this was a 61-year-old male, again, diabetic mellitus. He had a fracture 4 years later. Now, this is what we did at our place. We did it, we fixed it, and 4 months later, it was showing good callus, but then he had swelling, pain, and fever 8 months down the line. We had to remove everything because there's obvious infection. We removed the implant as well because you can see in the x-ray that the TKR was also loose. So we had to take it out, and now he's left with this picture. So he's got multiple screw holes on the femur. He's got obviously a small defect on the femur as well anteriorly. And this is 4 months later. He was treated, I think, he had 2-3 bugs. He was treated antibiotics IV followed by oral. Infection settled 4 months later. So we did a CCK type of fixation, and we used augments and got back his range of movement and sense fixation, stem down the femur. Again, if you notice carefully, is there a pointer only for this one? You look at the lateral x-ray, there was a small crack on that anterior cortex. So this is again a situation where there's a previous fixation on the femur. There is trouble negotiating down the femur, especially when there's a plate fixation. But I don't have his follow-up x-rays, but he went on to unite. So just to put out the fact that the femur navigation would be a problem, but otherwise we got a stable fixation, CCK type of construct, and with the stem down. And he's a diabetic, so that's probably why he got infected with the plate.
Very good.
Thank you. Any? Yeah, then one more.
So last talk on revision TK, Dr. Derek Peck, and then we'll have a short Q&A session. Okay. Thank you.
Thank you. So this is going to be a very quick case. This is another colleague, and it could have equally happened to me. There we go. So they had a primary knee replacement this year. 72, poor mobility using a frame, BMI of 43, poor range of movement, and she'd had carcinoma of the bowel 4 years previously without evidence of recurrence. So that's the pre-op, a very straightforward and standard X-ray, you would say. But unfortunately, her rehab was very poor. She fell 4 days following post-op on the ward, getting out of bed, and was unable to weight bear. Pain in her right knee was still slightly improved from the first day post-op, but she was noted to have a painless foot drop, and the peripheral pulses were palpable in the feet, which will be why I mention it. So, talking to everyone, including the patient, she fell and this happened rather than this happened and she fell. So this is a modern knee replacement, which was cruciate retaining. So any trainees out there want to say what you would do next? Cruciate retaining, yes. I suspect looking at her mass, if she was falling, it would have jumped over a post anyway, but you don't know. Sorry? Yes, it's going to be a problem. So everyone wants a CT scan. So you get a CT scan, and of course, just like if it was a native knee that had dislocated, you want to be cautious around intimal tears. So there's 3-vessel runoff, and that's in a brace. But you might say, well, we could just leave it in a brace, and all would be good. But the trouble is, when she's in a brace, she also does that. So she's not very stable in inflection. So it was decided that it would be revised, and I suppose the answer's come up before with the tibial plateau fracture. When would people revise? And to cut a long story short, you want to really let the soft tissues settle down. It seemed to be in the right place, held an extension. She could transfer from bed to chair, but everyone was very cautious about her. And the 3 weeks was the pragmatic time to let the soft tissues settle down rather than go straight in 5 days after surgery. And just as you said, a hinge was made available. That was her X-ray just prior to surgery. So you might say, well, you could probably leave it. But if you look at the gap, and if you could just see there seems to be a lot of fresh air here. You can just see it was obviously a large poly, and I am a little bit concerned that the PCL has definitely gone. Whether it had gone before, I wouldn't know, because the tibial cut doesn't seem to be particularly poor. And so that is what they did, a semi-constrained implant with a patella. And we're often taught, if you're doing a revision and the patella hasn't been resurface the patella to get better tracking. Again, I think we could debate that, and we just do not have time. A sleeve was used for the tibia. I think they were very surprised because they had a hinge on the shelf, but they went ahead with this, and they were very happy with the stability. But time will tell, and I'm sorry I haven't got any more follow-up than 3 months. Thank you. So, George, yeah.
We'll have a quick Q&A session before dinner.
Yeah.
Any questions from the floor? Then, yes.
Sir, the last knee that you showed, which dislocated.
I'm sorry, I didn't get the last knee I showed.
The last knee that you showed,
Yeah.
where she fell down and she dislocated.
I still can't hear that.
The knee was dislocated, yes.
Yeah. Yeah.
The knee got dislocated because she fell down without the fracture. So was a CR knee not indicated in that case? did you not assess the PCL deficiency? It must have been a PCL deficient knee to start off, and it was not diagnosed properly, and a CR was done, and therefore she dislocated, is my contention. Would you agree or you don't?
PCL laxity or
Yeah.
PCL injury
Yeah.
on table was not detected, and she warranted a PS knee.
Yeah.
That went
Yeah,
undetected.
no. Yes, sorry, I fully appreciate that. I wasn't there at the time of the primary surgery. I suspect it might have been, but I think if you look at all the studies that look at cruciate retaining and cruciate sacrificing, a lot of the cruciate retaining, the PCL is not functioning normally, and there is a great deal of laxity. But I think this lady, whether it was the soft tissues, her obesity, and just the way she fell resulted in that. But I agree, if I'd been there and I'd noticed that it was, there was a problem, I would have gone for a cruciate sacrificing knee. But I just fear that I think it might have just jumped over looking at that, and I have seen that in the past. I've seen an IB2 do that in my training years.
Mr. Derek, there's a question to you because I'm asking this because one, your mentors are from Wrightington Hospital.
Yeah.
Second is you're a debut person. So I just want to understand your thoughts on with the taper slip stems in the hip causing more periprosthetic fracture and composite beam coming back. Is still Charnley stems available? And second is with the collarless uncemented stems having more fractures. What are your thoughts on that?
No, it's hip.
You're talking about the hip, right?
Yeah, hip, yes.
Yeah.
Well, I was going to say, should we have a conversation about that later? But I would say I still use a tapered polished stem. I think things have got to fail at some stage. I know the CPT made by Zimmer has been withdrawn by the company in the UK because of increased risk of periprosthetic fracture. But as an overall, if you looked at all outcomes, it wasn't an outlier, which is interesting. So the composite beam, I think, yes. I mean, I've used Charnley's for a long time, and they still occasionally come back, and I think, why did I ever not use that? But I then look at the 22 head and think, wow, that was small. With a modern poly, I think you can get away with much larger heads, which produces the stability. I think the uncemented, I was tainted when I saw in early days, I saw more fractured femurs produced intraoperatively with uncemented techniques for a hip replacement than I ever did as a trainee with patients falling off their motorcycles and jumping off bridges and so forth. So yeah, we can talk about it, but does that answer your question?
Yeah,
No,
just the collar versus no collar.
The
We'll discuss later.
increased rate of fractures with uncemented femurs, because especially in the UK also, Bevelin brought out a big series because they were using it for fracture neck of femurs, slightly in the older people, not like us. So there was some subsidence, and that's the whole reason why the evolution of the collar also came on. So that is the reason why everything else
Yeah.
also.
Yeah,
So
look,
that's also one of the questions that you were asking about, increase in periprosthetic, fracture neck of femur.
Have you stopped using collarless stems now? Yeah, Dr.
No,
Anil?
no, we don't use collars as a, collars come as a part of the short neck, which we use, but not standard collar.
So in metaphyseal defects, so do you have a preferential thing to use either sleeves and cones, or do you use both, or it depends on what?
50-50, because the only thing is, if I'm going with the system that, because sleeves ties you down to one system.
Yes.
You cannot use it with anything else.
yes.
So I think cones are little more advantage because you can use an offset stem, you can use any system actually.
Yeah.
You can marry two systems actually. So cones are a little better.
Yeah, I mean, likewise, I would go with a cone if needed, but if I can get away with just using
Right.
I used to use sleeves, but now I'm tilting more towards cones.
Yeah.
yeah.
So any other questions on the floor? or
This
else
is
we-
to Dr. Sunil. So when you do revision, a lot of metal debris will be there. You prefer to remove all the, I'm here.
Oh, okay.
Yeah, you would like to remove all the metal debris, or you would like to conveniently leave?
When I take out the implant, yeah, I would like to take out the debris. There's a lot of cement in the canal, so we'll have to take out all the cement. Otherwise, the next cement will not integrate well. So you take out, curate all the cement before you actually
No,
start.
I'm not talking about the cement. The metallus is lot of metal.
Yeah,
things. One
Yeah.
of the X-ray what you have
Yes.
shown.
Yes.
I'm not sure
Take out
whether
as much as possible.
Whatever
Take
is
out as much
possible.
as possible.
Whatever is possible.
You don't, it's not necessarily through a direct radical debridement because vasculature and things like that. So you take out as much as possible.
So it's according to surgeon convenience, how much you can remove, otherwise leave it. That's what.
Yeah. Another last question probably is the choice of stems when you're doing a revision. Do you use long uncemented fluted stems or you like to use short stubby stems cemented? How would you?
I've always tended to want to use short cemented stems, but I have and still use an uncemented stem when I think it's appropriate. And I think they were both were shown on cases today. And I think rather like the cone and sleeve debate, I think it's you kind of got to go with what you feel. I don't think we have the answer. Yes, you've got to cement. You've got to use cementless at this stage.
Both do well. Short stubby stems, cemented, do very well.
Yeah.
You don't need to go long if you're happy with the fixation of the short stubby.
Yeah.
That's the best way to put it.
And I think the phrase you used, use the minimum implant that you can not get away with, but that's suitable for the patient.
Right. So if there are no more questions, probably we'll close the session. I'd like to invite.
Thank you very much. Off to you.
So, I would like to thank our all the faculties who have participated and made the sessions very interesting. Yeah. So I think so. There are a few questions related to trauma. Let Dr. Amarnath come and the faculties answer before we do with our final felicitation and closing ceremony.
Thanks, sir. Thank you. There are a few more questions before you. Absolutely. Now, do you have the mic there? Working mic? Could somebody adjust the mic for me, please? Yeah, here we go. Yep.
This one works. We're good.
Right. What are the tips and tricks to avoid semi-complications by multiple insertions for comminuted high-grade pilon fracture?
How to avoid complications.
Yeah.
So the pilon fracture,
With multiple infections.
multiple injuries. So in the polytrauma patient with multiple injuries. So I think typically in a pilon in a polytrauma, it will be a staged fixation for me. So the first thing is to keep it with an X-fix and wait and multiple incisions. So my rule where possible is 2 incisions maximum, which is why I talked about the paired incisions being as far apart from each other as possible. So 180 degrees if you can. Occasionally you can make a small third, little mini incision for inserting a screw or a periosteal, but 2 incision maximum is my rule.
Thank you. Now, question to you, Alex. Medial plate for medial fixation of femoral condyle. Do you have properly contoured plate? Dr. Jha from Patna is asking you. Do you have a contoured plate for that fracture?
So on the market, there are a couple of pre-contoured periarticular plates for the medial distal femur. Full disclosure, I've just been involved in designing Stryker's new medial distal femur plate, but it is only out in the US at the moment. But you can take any plate. You don't need heavy hardware. You can contour a 3.5 DCP. A lot of people like using opposite side periarticular plates. So you take the contralateral, lateral distal femur and put it medially. You can take a phelos plate, a distal tibial plate. It doesn't really matter. Most of the time, you're either doing a little buttress plate, so you don't need any heavy duty, or if I'm doing a long plate, MEPO from medial condyle to lesser troch, I just take a big DCP and put a bit of a twist and a bend on it. You can use anything.
There's a question for Ajit. There's a big question here. In case of comminuted tibial fracture with impending compartment syndrome, we are using technique of primary fasciotomy, fracture fixation and incision wound care with primary VAC therapy and grafting or secondary suturing later. What are your thoughts on this?
What is the second part of the question?
Second part of the question is fracture fixation and incision wound care. It says infection maybe. Wound care with primary VAC therapy and skin grafting or secondary suturing. What would you prefer or what's your thoughts on?
Yeah. Most of the time you would end up with grafting. You would end up with skin grafting. The important thing is you can place your fasciotomy incision more posteriorly and your definitive fixation incision will be anterolateral. So there will be two different incisions for that, and for the original fasciotomy incision, most often we have actually put in a skin graft, split skin graft.
Have you got any experience with amnion chorion? That
No.
is the, yeah,
No,
no grafting, okay.
no.
Okay.
Only we've
That's
used
the
VAC.
placental grafting.
No.
Okay. Now, question for you again. Is it necessary to put 3 plates, whether posteromedial or anterolateral plate? Would that have been sufficient?
That all depends on the fracture pattern and how you fix it, because that particular fracture, the big chunk was posteromedial, and then towards the fibular head there was another fragment. So you needed 2 plates, 2 separate plates. Sometimes in the earlier times when the anatomical plates were not available, we used to use the conventional T-buttress plate of the tibia on the back, and that served the purpose because it was quite broad, it would address both the fractures. But nowadays you have slimmer plates which you can use, multiple plates. It's not the question of the number of plates, it is how you handle the soft tissues and how you play around with the soft tissues.
Correct. Now, there's a comment on, for I think Alexis, from Dr. Karne from Pune. He says one of your slides showed the nail was put too anteriorly. That's why the distal fragment was in too much flexion. Also, is the nail better fixation than a longer plate of a distal fracture?
We're talking in the distal femur. I think,
Yeah.
I mean, so a small amount of flexion or extension of the distal femur doesn't seem to be a major problem. Sagittal plane malalignment is much more forgiving than coronal plane. I don't think it was too flexed. I think there was some posterior comminution on the condyle. I would always try and get a nail in a long bone fracture over a plate wherever possible, because I think